Great. Good morning, everybody, and thank you for joining our weekly Monty Hardcast conference. And today it's really great to have a very good friend, Gregory Sgueglia, who works in Rome. I've known Gregory for a number of years, and he's really an expert in many facets of interventional cardiology, extremely well published. One of the areas I always pick on him to come teach us on is Radial PCI, because he's really truly an expert. He published books on the use of the radial, even the use of distal radial for every intervention that can be done via the radial. And so he's very well known and well researched in the field. So, Gregory, you know, just to tell you a little bit about the US, our center in New York, I think when I arrived, there was a lot of radial we have two hospitals, a lot of radial being done at one. I would say maybe 50%, 60%, and maybe 20% radial at the other one. And slowly over the years, it's increased, but over the last 6 months, we've really now been pushing hard to become a radial first center. We've made it a quality metric. So our one hospital is just above 80, the other one is probably 60 to 70. It's a measure we look at every month in our monthly sort of quality assurance meetings. We did the same thing with intracoronary imaging. So our center does sort of intracoronary imaging in more than 90 to 95% of PCIs. So very high. And
Right.
so this is
Mhm.
also a huge important quality metric for us. And as more and more people do it, obviously challenges come up, right? Because you're now trying to do more and more complex procedures. And that's why I thought it would be great if you could share some tips and tricks with us. I just wanted to give you some background.
Thank you. Thank you so much, Azine. Thank you for this wonderful opportunity to be here and share ideas and concepts about an important topic, I guess. Actually, the benefits of radial access are well known. Some are related to the patient, some are related to the operator, others are related to the healthcare system. And I'd like to highlight the reduction in mortality that has been shown in meta-analysis to occur across the whole spectrum of patients with coronary artery disease. And this is something that I mean is very important when treating patient in whom the procedure is actually not expected to have an impact on mortality. And also, when we see patient level meta-analysis data on the right, this is the landmark analysis. This difference is expected to occur very, very early after the procedure. So it's concrete gain. And no doubt that scientific society guidelines have recommended radial access as a class 1A indication for percutaneous coronary procedure. And for the same reason, it's quite obvious that radial access is increasingly adopted across different interventional specialties and for multiple indications. So patients are becoming and are going to be frequent flyer of radial access, and therefore the practice of radial access is dual in my view. Is not only directed to the success of the procedure, transradial procedure, but it also mean to the preservation of radial access. And this is for compliance to the guidelines in the future, and so for offering the patient all the advantages and the benefits that have been demonstrated. So the very first step is actually to determine the optimal radial access site, and now we have three options. We have the conventional transradial puncture site at wrist level, and we have also distal radial access with two puncture points in the dorsal hand. And it's very interesting that the latest guidelines, American guidelines on the management of patients with acute coronary syndromes recommend a radial access, and in the text it's clearly indicated that the option is between actually conventional transradial access or radial access. So A good tool to assess the best puncture point is ultrasound. I like very much what I call the next future is handheld uh, ultrasound, which actually allows to translate and practice the possibility that are offered by something like a smartphone that can be easily fit in the pocket. I'm not sure care carrying on and using a large and a heavy machine would be a real option for assessing the patient. And these are two examples. Actually, you can easily, when talking to the patient and presenting the procedure, you can measure the access point, diameter of the arteries, and also scan all the forearm for assessing for possible issues. And when the optimal access point has been determined, there are a few things that can be performed. Anesthesia for sure. You can also use cutaneous nitroglycerin or ulnar compression. And actually, there are data in favor of those strategies, and you see on the left, the use of nitroglycerin actually increase the diameter of a radial artery that is measured at the end of the procedure. In contrast, when using a placebo, the diameter of the radial artery at the end of the procedure is actually reduced. And similar findings are actually found with transient ulnar compression that is beneficial in terms of increase of the cross-sectional area of the radial artery, and also in the reduction of the access time. Okay, sorry, yes, have an issue here. Okay, it's fixed. I cannot move on.
Maybe just exit
Uh-huh.
and then re-share your slides again, Greg. Sometimes that works. It's kind of weird.
Okay, so let's do this. And okay, that's
Funny.
good. Okay. And at that point, ultrasound guidance is an option that is certainly to be considered just to improve the chance of an optimal access. And this is especially when performing this toroidal access. And we have actually some data in favor with there is a randomized trial, the ROLS trial, that compared palpation-guided puncture to ultrasound-guided puncture in conventional transradial access, multi-center US trial. And actually, it demonstrated a significant reduction in the number of attempts for successful puncture. We have data also in the field of distal radial access with very high rate of success with ultrasound guided access, and we know this is something that may be very important because the success that is linked to distal radial access is certainly a limitation for a widespread adoption of this access. This is a practical tip just to guide. This is probably the easiest way to puncture a radial artery. In this particular case, is the distal radial artery. So you just place the needle horizontal over the image, the circular image in transversal plane of the radial artery. So it's visualized by the ultrasound, and then you tilt your needle and you go into the skin until you reach the artery. It's very nice. Another advantage linked to using handheld ultrasound probe is that the probe can be ready when preparing all the equipment for the procedure, and as you see, it's quite easy to access the radial artery. There are two puncture techniques that are implemented in everyday practice: the anterior wall puncture technique, and then the through and through technique, which is the transfixion technique with the catheter over the needle. And actually, as it comes with conventional radial access, both can be used. Probably when performing this radial access, because of the very short distance between the artery and the bone below, the through and through technique should be avoided in favor of the anterior wall technique, just to avoid transfixing the distal radial artery and touching the periosteum of the trapezium or the scaphoid bone, which is something that is going to cause significant pain to the patient. So this is something that we should take in mind. And also, when talking about this radial access, we have to consider the curvature of the vessel. This means that the entry angle to the skin is probably different as entry angle to the vessel, and this required some kind of adaptation of the entry angle when targeting different spots in the distal radial artery. So when the puncture is actually performed, that the next step is the mini guide wire advancement in the artery. This is a step that should be extremely smooth. So if there is an issue as to stop, so sometimes we have here some difficulties with the equipment. It's really important to have good equipment. This is an example of a dual needle that feels to pierce the skin, and also sometimes. Sorry, is this comment for me?
No, carry
No.
on, Greg.
Okay. I kind of. Okay. You see here the redirection of the needle is an example of how we can improve the advancement of mini wire. And in this video, the redirection is done under ultrasound guidance, just to confirm that the needle is really in the true lumen of the radial artery. There are new tools that are emerging. This is a proposal for a new wire with a very smooth distal end that should avoid producing dissection in case of impingement of the posterior wall. And as you see, the first pass success is even better when using this wire than as with ultrasound puncture at all, and it's far better than when the puncture is guided by palpation. This is something that is worth to know when intimal flap is produced during the puncture. Is quite difficult, even if improving the entry angle to gain the true lumen when the puncture is performed at the same site. So if we are in a conventional puncture site in the wrist, one thing that can be done is accessing the distal radial artery and taking advantage of the flow, the orthodromic flow that will oppose the dissection plane. The probability to gain the true lumen is quite high. So this is a nice tip to take in hand. Okay, so another thing that may happen is because of some curvature or some tortuosity, the mini guide wire will not advance. So you may want to know if you are really in the true lumen or not. So you change the needle for the calf of the needle, which can confirm them the true presence in the presence in the true lumen, and favor also the advancement of the mini guide wire. Yeah, a time you see on the left, the guide wire is not advancing. So when those situations happen, but the threshold for producing an image, for producing an angiography should be very, very low. Every time something doesn't work as expected, we know that the radial artery is like a straight tube. So if something doesn't go smoothly, it's really important to acquire better knowledge. And after having a geography, it's quite easy to find the best path for the advancement of the mean guide wire. So at this point, we are in full setting for reaching the coronary arteries, and one guiding principle is really to select the smallest equipment, the smallest gear possible, and this is really a similar work from Japan. These are two frequency distribution of the size of the diameter of the radial artery in men and women measure before the procedure. Actually, one day before the procedure. Then, but the procedure has been done, which is something nice to consider anyway. And when comparing the measurement, it came out that about 20% of men and 40% of women had a measured radial artery that was smaller than the introducer sheath that has been actually used for the procedure. And this has drive kind of endeavor for developing better tools, and this has actually been the driving force for the development of the thin wall sheath, actually the slender sheath. And the benefit of using such a device in small radial arteries, is to reduce the sheath to artery ratio, which is expected to produce some damage to the artery. So when just adopting this smaller sheath, the thin wall sheath, you see how the proportion of patient men and women that had an artery considered to be smaller, excessively small for 6 French or conventional transradial access is significantly reduced. So the impact is quite evident here. And the issue of size is really important. You see on left, it's also a similar work. It's from Germany. Actually, they systematically implement ultrasound check of the radial arteries after the procedure, and they found a striking difference. Found an extremely high rate of radial artery occlusion. This is a point for sure, but the striking difference when comparing 6 French to 5 French access, and this occurs even in the most tiny setting when comparing the 5 French conventional 5 French introducer sheath with the 6 French thin wall that should have the same external diameter as a 5 French introducer sheath. But it's not exactly true. There is a very, very tiny difference, but still this tiny difference is responsible of an advantage in terms of production of radial artery occlusion. Difference here is not significant, but the roll rates are quite evident. And also, it's beneficial to operate this downsizing at any step of the procedure. In we compared in this registry, we enrolled short frame women just to have a high proportion of small radial arteries, and we compared two workflow. The first workflow was using a 6 French for everything, because 6 French is considered the most universal approach, allowing to perform almost every kind of everyday procedures, and we compare that with using a 6 French introducer that would allow to advance a 6 French guided catheter, but we use 5 French diagnostic catheters. And what came out is that when looking at the incidence of radial artery spasm, it was significantly lower with the Lewis woman workflow, and also the referred pain by the patient was significantly lower with the Lewis woman workflow. So reducing the caliber, even for a specific step of the procedure, is anyway rewarding. This is a meta-analysis showing the advantages of implementing a shiftless approach. This is something that probably will become rapidly old age, but perhaps it may warrant some kind of revival. And you see on the left there is a benefit in using a shiftless approach on the incidence of radial artery spasm and access site crossover with no penalties in terms of safety and efficacy of the procedure. So the setup has been completed, and when moving in the path to the completion of the procedure, administration of antispasmodic and anticoagulant, the cocktail, is certainly something to warrant to the patient. And at this point, it's really relevant to focus on the advancement of the guide wire or the catheter in the radial artery. So it's more interesting to look at what happens and what to do when this is not smooth. And so we know that in general the radial artery is a straight tube, but sometimes there are loops, sometimes there is tortuosity, and this is certainly an issue. And you see data from an important radial center in North America, and data from a very relevant multi-center randomized trial with an expert radial center, and the rate of failure is quite high. And this filter neutrals too. This trial assessed the efficacy of using what is called the baby J, which is a guide wire with shorter radius for the distal curvature, and you see the technical success of the procedure when implementing this tool is probably is significantly higher, which is really something to take into consideration. So when typically you finding tortuosity, and the first step to implement is using an hydrophilic wire. On the right, you see the wire that has advanced very easily, probably too fast. It's always important to be very cautious when using this kind of wire, and also avoiding knuckle events, because it may increase the risk of radial artery dissection. There are pitfalls for sure. You see the angel on the left, and this is the advancement of the hydrophilic guide wire, which seems good. And but actually it corresponds here to this minuscule branch, and if the catheter would have advanced here, some damage had to be expected. So it's really important just to every time acquire the angel, fix the angel, and follow the path, really to be sure to respect the anatomy. It's also important again to refresh one's knowledge, and to really take in mind the possibility of gaining an accessory or a collateral branch. When it comes to loops, again, the strategy is using first line strategy is using the hydrophilic guide wire, which is most of the time sufficient to straighten the loop and allowing the advancement of the catheter. But a technique that's further has to be mastered is the balloon assisted tracking that implies using an inflated balloon at the tip of the guiding catheter that is advanced over a coronary wire, and it's like a bumper, and it's really improve the trackability of the catheter, avoiding the razor effect. A variant is to use the pigtail because the pigtail is progressively reducing diameter its distal tip, so it produces this kind of transition between the catheter and the guide wire. There are over options for achieving this kind of transition, smooth transition. The option offered by dedicated shiftless system is for sure optimal. This can be mimicked by a long dilator. There are some manufacturers producing long dilators. Balloon assisted tracking is an over option that implies as a limitation to require a coronary guide wire, which is less supportive. And the pigtail assisted tracking is also something that can be considered. The child mother technique actually doesn't offset the limit of the razor effect. And this is an example. You see here there is this loop connecting the radial artery to the brachial artery, and this is an example on the right of balloon assisted tracking. It's probably a 5 French catheter since there is only one marker in the balloon, so it's a 1.5 marker. The balloon has to be smaller than the internal diameter of the guiding catheter, and you see how slowly but effectively the catheter cross the loop. So this is the image the angel we already seen earlier, and you see here in the central image the attempt to advance a catheter over the hydrophilic wire has produced this spasm. And what is interesting is that the strategy was to switch to balloon assisted tracking, and at this point there was some issue. And what happened? The coronary wire actually entered this branch here. So the catheter stopped at the origin of this branch, and the angel confirmed this confirmed the issue. So there was a right direction of the wire, and then check with the sliding balloon, and finally optimal advancement with balloon assisted tracking. Okay. In general, the straightening of the loop is quite spontaneous, just with a little bit of maneuver and torquing the catheter. But at time, you need to really straighten with a stiff wire, which is another option to consider. This is the previous case. So the advancement of the hydrophilic guide wire provoked spasm, severe spasm on the arterial segment that was down upstream the loop. And this is just to show that sometimes it is important to administer increasing dose and the reiterated dose of nitroglycerin just to solve the situation. It's also important to have some knowledge of the variance that may affect and the transradial axis. This is one of the most typical, is the high takeoff of the radial artery, this or sequential image from downstream to upstream, and you see here this is the brachial artery with this takeoff. In general, those high takeoff radial arteries are very small and very prone to spasm, and a good strategy is to track the catheter, implementing the balloon assisted tracking. You see that on the right. Yeah, it's really effective. Okay, another variance that is important to know is arterial dysuria, and actually this is certainly something that may discourage the strategy, and perhaps should prompt the switch to the other side. So at this point, we have to consider the tracking of the catheter to the aorta, and sometimes because of tortuosities, we have to rely on the use of stiff wire. This is a stiff wire that allows better manipulation, a more controlled manipulation of the guiding catheter, and facilitate the engagement of in the left coronary ostia in this particular situation. At times, it's quite difficult to cannulate. This is an example of abnormal origin of the left circumflex, and what can be done is just to advance a coronary guide wire to stabilize the catheter and favor an optimal coaxial engagement and allow for angiography. So when coronary arteries are engaged, and just to perform the PCI, there are some strategies to implement for sure. The choice of small size equipment may reduce the support. So probably your best friend is the body wire, the anchor wire. Every time you have some issue with the advancement of a balloon, of a stent in the coronary artery, very low threshold for using a second coronary wire, and most of the time this is something that is really going to help your procedure in a very successful way. The 5 French guiding catheter is paradoxically a very nice option, because it allows deep intubation. Sometimes we may think that we need a larger caliber, larger bore guiding catheter, because we need a catheter extension and something like that. But actually, this can be easily and very efficiently done with the 5 French guiding catheter. So it's important to know what actually can be accommodated in a 5 French guiding catheter, and this is a table providing the effective compatibility of devices. And I guess that really a lot of procedures in an everyday setting can be achieved with the 5 French guiding catheter. So it's certainly an option to consider. And okay, so the procedure is actually not finished when the PCI is finished. One thing that is very important in view of the respect of the radial artery is removing the catheter over the angiographic guide wire. Sometimes for going fast, this is a step that is avoided. You see on the left, this is a withdrawal of the guiding catheter, or on the coronary wire. This was an attempt of balloon assisted tracking, and actually this is what happened. It's like a kind of rate riser effect that produces multiple spasm. So very important to assure this step. Aspirate from the introducer shift side port and administrating nitroglycerin and the end of the procedure are two easy steps that have been demonstrated to improve the rate of patency of the radial artery in the follow-up. And no, the very last step of the procedure is actually hemostasis, and hemostasis is important to reduce radial artery occlusion. Radial artery occlusion is composite phenomenon. There are different interacting elements and that act often in the opposite way. And you see on the right, it's a simulation considering a rate of 5% radial artery occlusion in a given center, and just with arithmetics, this is the predicted rate of not being able to perform the procedure, the rate of finding an occluded radial artery with increasing number of procedure. And going back to what we have considered at the early beginning of the presentation, this is something that we have to consider with greater and greater interest. There are many factors that have been associated with radial artery occlusion. Some are not cannot be modified over yes, and so we have to really to work on them. And probably the two most important elements or two most important strategy of preserving the dependency of the radial artery during hemostasis. And you see on the left, this are data of the PROPHET study, the very first study that assessed the role of patent hemostasis, meaning just implementing a strategy for ensuring the non-occlusive hemostasis. And it's really interesting to see also that the duration of hemostasis is something that is very important. These are data of RAP and BEAT trial that compare conventional 5 French to thin-walled 6 French sheath, and the difference in the hemostasis time mimic the difference in the rate of radial artery occlusion between Japanese and non-Japanese patients. That the concept here is that in Japan there is this tradition of prolonged, very long hemostasis, and this is something that certainly has an impact. So the main drivers for an optimal hemostasis or patent hemostasis, something that has been more recently suggested, is the ulnar artery compression, just to actually take advantage of the kind of dilation of the radial artery, metabolic driven dilation of the radial artery, and also working on hemostasis duration. But when looking at the distribution over time of the radial artery occlusion rate in different studies and different trials published over a 10-year time span, it's quite evident that this is something that is not actually working even in the most dedicated setting. So it's probably very, very wise to look at emerging approaches in hemostasis, and this radial access is one of them. I like to summarize the results of this co-radial trial, which was a non-positive trial because of the very low rates of radial artery occlusion in both groups. But it's nice to see when paying attention in this trial, radial artery, this radial access was compared to conventional transradial access with implementation of all the tools, all the the techniques for reducing radial artery occlusion. So the point here is that you have to do something just to lower your rate of radial artery occlusion. You can choose, you can implement all the tools and techniques at the same time. It's cumbersome, it's time consuming, or the alternative is this radial access, which seems to provide a quite spontaneous way to reduce radial artery occlusion. This has been then showed in many meta-analysis. Another option is hemostatic patch that has been assessed in this American multicenter trial, the STAT2 trial. They use a potassium ferrate patch, and it's very interesting that the rate of radial artery occlusion with the patch is in the very same range as what is achievable with this radial access. And again, the comparator is conventional hemostasis with dedication to reducing radial artery occlusion. And the final message here is that really there are options, and those options are effective, and those options are certainly to be implemented for reducing radial artery occlusion and allowing us to continue performing radial access in our patients. And this is actually the very final consideration of this talk, is always be active and proactive in finding the best balance between efficacy and safety in transradial access. I thank you very much.
Greg, thank you as usual. That was really excellent. I have a lot of questions, but I'm sure that the team has lots of questions too. I see lots of hands going up, so I'm actually going to let them start answering first. Hang on. So, Jude, I saw your hand go up first. Why don't you start?
Can you hear me?
Yes, we can.
Okay, good morning. Thank you. It was a great presentation. I'm happy to have you join us at Monty Heart. Two questions for you. So number one, you sort of glossed over the cocktail that you give, and I'm curious to know what is in your cocktail and specifically when you give it, and why. And then the second question is, what is your experience with ulnar access versus radial access? And if you have any tips or tricks of when you use the ulnar versus when you do radial access.
Greg, you're on mute. You still on mute, Greg.
Mute.
There you go.
And no.
Now
So
we can
okay.
hear you.
Yeah. Okay. Sorry for that. I had the opportunity to work in different hospitals, and the cocktail was always different. But actually, the two main element, anticoagulant is important. Anticoagulant is shown to reduce the rate of radial artery occlusion, and since the radial access or this radial access as well is very safe in reducing hematoma or bleeding, it's really wise to take advantage of that, and I don't see any reason for avoiding anticoagulant, and this is the first point. And the second element of the cocktail is an antispasmodic agent, so you can use nitroglycerin or a calcium antagonist or a combination of both. There are a lot of data about that. Actually, every strategy is working, and so the point is use something, and this is wise. The antispasmodic drugs don't have a systemic effect. They are locally distributed, and so you cannot expect a reduction of blood pressure. Sometimes it happens, patients have a vagal reaction, but because of the fear or perhaps the pain during the puncture, not because of the drug that had been administered. Ulnar access, the ulnar artery is in general, the big artery of the forearm, the nurturing artery of the hand. So it's second choice. It's second choice definitely because it is probably more important. The ulna bone is in an oblique plane below the ulnar artery, so the compression is less reliable, and data are not as much as those available for transradial access. And I would recommend using ultrasound guided access when performing ulnar access, just to be sure to puncture at 12 o'clock and then warrant an optimal hemostasis.
So we actually 100% here for radial and femoral access. We teach all the fellows to get all the access, arteries, veins, femoral, radial ultrasound. And so we have an ultrasound in the room, which has really helped in every cath lab, so you never go to look for it. Greg, let me just ask you before we move on to the next question, just a question on what you said. So for heparin, clearly the data is there. There's even randomized data that it decreases radial artery occlusion. Is there any randomized data for any of the antispasmodics?
There are a lot of small trials actually comparing different regimens, and there is no sign of, as far as I know, that are in favor of one regimen compared to another regimen. So the point is using the antispasmodic is effective.
Okay, thanks. Mark, I saw your hand go up.
Yes, thank you. That was a wonderful overview. One thing, years ago, we were doing the reverse Barbeau test routinely, and then the guidelines got away from it. I still do it occasionally if I don't feel a good ulnar pulse or I'm not satisfied there's an ulnar pulse. Do you use it, and do you rely on it?
Well, we have actually stopped using it after a trial has assessed the effective benefit of performing that systematically, and the result with multiple endpoints is not in favor. So it's typically consider time not well invested. Sorry, you mentioned reverse test. Yeah, just to check if this may have sense when the patient has already been catheterized from radial access, and you want to check that the radial artery is still patent. This is the point. This is something that can be done, and it's a good choice. But actually, I would say that ultrasound assessment, ultrasound guidance is something that should be nowadays implemented on an everyday basis. It really elevates the international practice. So, well, I'm not sure it's any more useful. No, it's something that belongs to probably to the past, when ultrasound was not couldn't be implemented on an easy way. And when you see how it's easy to do that with a handheld device, I'm not sure there is any justification against that.
Okay.
Understood.
Corrado. One.
Yes, Dr. Sgueglia, that was an amazing presentation. Thank you so much.
Thank you.
I'm a third-year fellow. I'm applying for interventional cardiology, and I'm trying to, to perform my pre-interventional training. And when we facing this issue to remove equipment from the radial artery, sometimes I heard that many interventionalists mention the flow-mediated dilation as a potential technique to help removing, especially the long sheets from the left radial artery. What is your experience with that technique, and is it successful, or is just like a theoretical, approach that is not like on a daily basis usage? Thank you.
Flow dilation is requires some time, and so I don't expect it it is used alone. So it usually comes after nitroglycerin or verapamil has been administered, or using hot gauze just to promote dilation and perhaps sedation. So it's on top of over strategies, and so it's difficult to separate the effectiveness of flow-mediated dilation from the action of the over strategies. Probably it's a beneficial effect of all those together. For the flow-mediated dilation to be effective, there should be some space around the catheter just to allow the transmission of flow, and actually that the dilation occurs. So if there is a very, very, very severe spasm that really entraps the catheter, I don't know. I really don't know if a flow-mediated dilation alone can work, but it's really important to implement all the steps just to remove the catheter in the safest and the most effective way.
Great. I'm gonna pick on people whose hands are up because I'm assuming they have a question. Manav.
Thank you very much for a great overview. That was really excellent to listen to. I have a couple of questions. The first is about patients with end-stage renal disease on hemodialysis who are getting dialyzed through a fistula on one arm. I'm a little bit torn about these patients sometimes because I want to offer them the benefits of radial artery access and the decreased bleeding and the mortality benefit. But I also know that there's evidence, even when the radial artery stays patent after a procedure, that there's some evidence of injury to the radial artery, and whether that affects future AV graft patency in that arm is still being determined. I was wondering what your approach is to those patients. Do you still access their contralateral arm for radial artery access? Do you go femoral? That's my first question. And then my second question is really quick, just about the use of long versus short radial sheaths, and if you have any comment on that.
Regarding the issue of hemodialysis patients, I guess it's something that is related to it in this institution. In my institution, it couldn't work for now. So we actually have elected not to approach those patients transradial. But there are even published data on distal radial access in those patients with a slender approach, meaning with the smallest possible equipment, just to create the setting for reducing as much as possible, not only radial artery occlusion, but also reducing the sheath or guiding or catheter to artery ratio, just to reduce as much as possible any mechanical interaction between the equipment and then the arterial wall. And this is something that certainly reflects a more higher interaction between interventional cardiology and nephrology in those institutions. So I guess it's work in progress. It's really work in progress, and perhaps in the future this will become a nice option, just to reduce even more to improve the outcome and reduce the adverse events in those patients. And your second question, sorry, can you just
long versus short radial?
Long. Okay. Yeah. Where I trained, the long sheath was mandatory. That's mandatory because actually the person in charge of radial access was the less experienced one. No, so it creates really the most predictable setting for a right rate of radial artery spasm. So they use this strategy as a trade-off, because it has been demonstrated the use of long sheath is something that has a high rate of damage to the arteriole. There are high frequency, high resolution ultrasound studies and also OCT studies showing from there. So it's trade-off. In my personal practice, I use short shift, and I'm really happy with that. I guess that if the puncture is optimal, if you use ultrasound guided puncture, so you potentially, and you're aiming to that, the very first insertion of the needle is going to be successful. So everything is going to be smooth as predicted, and the rate of radial artery spasm, there is no reason to expect a high rate of radial artery spasm, especially if just after that you administer some antispasmodic drugs. So I'm not certain that there is nowadays with a modern practice of transradial interventional cardiology, there's still a stringent need for long shift.
So it's interesting. I think Manaf is kind of digging at me to be called old. So it's interesting. I started my radial career doing short sheaths for the first 10 years, only doing short sheaths. And about 5 or 6 years ago, I went to one of my friends. I went to work a few days with another few colleagues in Italy, and they were using long sheaths. And and by long, we mean probably 20 centimeters, not longer than that. So it just gets you to the brachial artery. It doesn't go higher than that. And I have to admit, I saw the advantages of it. So I personally, in the group, everybody does what they feel beneficial. I personally still use long. I use 20. And it's a new change over the last 5 years. And part of it was when I was doing a really long procedure, multi-vessel, a rotor, left main, or a case, where it was lasting 2 hours or 3 hours via the radial, I was struggling with increasing spasm as the procedure went along. And so for those cases is where I started using it, but now I like it so much I still do. But anyway,
I still use it as well. I mean, I cath a lot of patients who have severe aortic stenosis, and the use of nitroglycerin is, sometimes contraindicated in those patients, and I find it hard to use these antispasmodics. So I use a slender sheath, which is long, but I am a little aware of some of the data that shows that there's higher rates of radial artery occlusion. So
right.
yeah, that was my question about how you approach those patients. I think, like you say, it's a trade-off, and maybe to use a short sheath when possible is probably the best for our patients. But thank you for that.
Let's see, Pierre.
Yes, thanks. I just had a quick question about your practice. And in terms of, we always talk about lifetime management of aortic stenosis, lifetime management of coronary artery disease. And, lifetime management of coronary artery disease goes hand in hand. Maybe someone can think with, also radial access and the kind of access that you can use any procedure that you do. So in your practice, what's your approach? Do you try and preserve the conventional radial? And first patient coming in, you try and go distal radial. And then if you were to happen and encounter radial artery occlusion, do you try in recanalization? And if you do you try from the conventional access, or do you try and do it from the distal radial? I'm just wondering a little bit about your day-to-day clinical practice.
I'm very fond of this radial access. I believe really it's a small investment that has an important impact on the patient career, and this is something that even the less experienced person in the cath lab can do. So this investment can be performed by really everyone. It's a skill to learn, but as interventional cardiologists, we're faced with a lot of skills to learn, and this is even a beauty of this of our job. So yes, this is. I think it requires. It's a state of mind. It requires a little bit of planning just to understand and find the sweet spot between between the comfort, the absolute comfort for the operator, and what is really something that will have an impact on the patient. We recently published a registry data about radial artery organization through this radial access, and it's something very effective. I would say it's something almost easy to do. It's very safe, and as it may require a time the implementation of CTO techniques, it could be also been valued as a kind of playground just for testing those techniques in a very safe environment. So I guess this is something to consider with higher value in the future.
Yeah. So, Greg, we do this routinely, or me and some of the team. I think we've probably recatalyzed over 100 occluded radials. And we've gotten so good at doing it that I hate to say this in front of Mark because he's going to think I'm nuts, that I don't feel the radial pulse anymore before I put a patient on the table. Because even if it's occluded, in probably our success rate with recanalizing it is well above 90%. Using ultrasound. So we'll identify an ultrasound, we'll make sure our needle is in the artery, and then we'll wire with different increasing wires, and then recanalize it with a longer sheath, and it's worked really well. The patient actually leaves the room with a bounding radial pulse when they had no pulse.
Yeah, and it lasts for longer even. Oh,
Yeah.
this is also, and definitely ultrasound is game changer in transradial practice.
Yeah. So we have two more questions, hopefully only. I'm sorry I'm keeping you late, but as you can see, the
No
team
problem.
love Radial. They want to get better. So Mohammed, and then John Maria and Andrea, see if you have anything.
Hi, this is Omar, one of the intervention fellow. Thank you so much for the great talk. In the beginning, you mentioned about subcutaneous nitroglycerin. So my question is any direct comparison between subcutaneous and the IV nitro? Because we give IV nitro as a part of a cocktail. And also, like, is there any dose response relationship? Can we give like multiple times during the procedure if we encounter spasm due to multiple manipulation of the guide catheters?
I'm not aware of comparative data toward intravenous nitroglycerin. I guess these are two independent steps that can be implemented. It's something very easy, is cheap, and really it could be even managed by mixing the nitroglycerin with lidocaine. It's something that has been demonstrated to work as well. And again, when performing the guiding the puncture with ultrasound, you can use ultrasound also to optimally inject the lidocaine or the nitroglycerin, avoiding a vein, because this is potential issue that may happen. You just puncture a small vein by chance, and then you don't have any more a local effect, but you have a systematic effect, and this is not what you're pursuing. So it's an adjunctive step, and you may adapt. If you notice, if you measure the radial artery that is very, very small, and the patient has a profile that increase the chance to developing radial artery spasm, perhaps that patient is a good candidate for a subcutaneous nitroglycerin.
John Maria, we're gonna ask now very quick questions. We have to let him go, and we have to go start our day. So let's go.
Yeah, thank you. Very great presentation. Quick question. We talk a lot about the preservation of the radial access, and sometimes, especially during coronography, we could have the kinking of the catheter. And I would like to know your experience about it, and how can you manage this complication to avoid the damage of the radial axis?
In general, kinking happens in the point of major stricture in the path. So it's really important to be used to keeping like a count of the clockwise and counterclockwise rotation you perform. This is something that certainly may help preventing that. When it happens, it's really crucial to localize it as soon as possible and implement the maneuver for relieving the kinking. This is something that definitely has to be learned and managed.
So
if you cannot counterclock the catheter, how can you manage it? How can you use something other device?
No, in general, you are almost always successful. The best thing is just prevention. No? So you really have to count what you are doing, but you can. There are a lot of maneuver. I really cannot summarize all of them. No.
we'll go through them with you tomorrow, John Maria. How about that? I want to get
Okay.
through some of the other questions. Asma, I'm going to get to you in a moment, but before people start leaving, one of the issues we've seen, Greg, since we've gone doing so much more radial, is we've seen an increase in two complications that I'm a little concerned about because I never used to see it before in Italy. So we've seen an increase in forearm hematomas. Okay. Some of them actually getting really bad where we have to get vascular surgery involved. And we've seen an increase in pseudoaneurysms of the radial. And I wanted maybe your thoughts on what are we doing wrong and what we should be doing better.
This is this is intriguing. I don't have any immediate explanation, unless perhaps reiterate puncture at the same site, perhaps at short distance doesn't allow a full restoration of all the elastic properties of the arteries. There's some scar tissue that still has something to play into that phenomenon. I don't know. This is perhaps an explanation.
It's probably related to TR band management. Afterwards,
perhaps this is something that goes beyond our control because it happens outside the cath lab. The higher interest in preserving the radial artery pattern and avoiding complication is for people in the cath lab. But those who are in charge of that are outside the cath lab. No? Yeah. And sometimes the attitude is different. People have in the past said, radial artery occlusion is meaningless. It doesn't have clinical consequences. So it's something that still has an impact outside the cath lab, and also not in all cath lab. The cultural appraisal is different. So training and retraining for the management of hemostasis, I guess it's really rewarding. In alternative, the use of an hemostatic patch is something that could be beneficial because it improve both the time of hemostasis and also the safety. So it's something to consider.
I've been reading some of the data, because when I worked in Italy, in Milano, we actually never used TR bands. We used a manual dressing, and I never saw hematomas or pseudoaneurysms. And I'm seeing a lot of it now. And it's happening not immediately, it's happening an hour, 2 hours later, even. So it's making me worry about, are we letting the TR band pulling off air too soon and then not realizing there's bleeding and pumping it up again and so controlling? I'm gonna do a trial of StatSeal and see, because I saw your paper, but I also read some other papers showing encouraging data. So I really like that. So very quickly, last two questions. I see Asma, you got your hand up. Andrea, you're very quiet. So Asma, go ahead.
Yes, that was a fantastic talk. Thank you, everybody, for the talk. Thank you for the talk and discussion. My question is that in times of radial artery occlusion, how comfortable should we be doing the ulnar access, and should we ever be afraid of causing hand ischemia because of that?
I would nowadays I would personally avoid, because data on radial artery recanalization are very convincing, not only about efficacy but also about the easiness of this approach. So I would really favor radial artery recanalization, or even before considering the contralateral radial access.
Yeah.
I prefer avoiding ulnar access for many reasons, especially
Yeah.
safety.
I do too. I've seen some of our worst complications from ulnars just because people struggle to gain hemostasis and so on. So I've been avoiding it. I used to do more of it, asthma. Now I honestly, it's so much easier to recanalize an occluded radial. So that's become my primary approach. Andrea, did you have any final comments?
No, I don't want to keep him like too long. I just want to say thank you for this great talk. I mean, we learned a lot. There is in this topic so much that we can still learn, and it's great to share your expertise with us. Thank you again.
Andrea,
Thank you so much.
Thanks, Andrea, for arranging. Greg, yeah, I don't know what to say. I always learn so much from you, and I learned today again. And I really appreciate you taking over hour of your time to spend with us and to teach us. It means a lot.
It's been a pleasure. Thank you. Thank you for
Stay safe.
Thank you.
Bye-bye.
Bye. Have a nice day.
Mhm.